Hi everybody, this video is all about a step-by-step approach for a retreatment. First and foremost, to begin with, we need to diagnose it well. And most of the times, diagnosis is all about radiography. However, a OPG will have a least diagnostic value. What you need to do is make an IOPA of the same tooth involved. In this case, it's going to be a 2-6 or the maxillary left first molar. If you see the picture, there was a coronal leakage happening. There was also an apical short fillings, lesion had developed, and it was a radiographic finding. In addition to which, the patient also had come to us with the clinical symptoms. When you correlate both of this, you will realize this tooth definitely needs a retreatment. So here we begin. First and foremost step is supposed to be caries removal and a pre-endodontic build-up, which means you're trying to open up or remove all the caries and try and get a caries-free sound tooth structure. Following which you will do a build-up and then re-enter the tooth. Earlier days we used to use cotton, then we use sponge in this case. Today we use Teflon. When we re-enter, the wall is maintained, that becomes a pre-endodontic build-up. We've used ultrasonics here to get in. I'm using a DG16 probe to pick it out, and here we have a concealed tooth with a wall built up, which is good like a reservoir to hold all the contents, and of course it's caries free. This is a pre-endodontic build-up. After which you need to get into the root canal system. When you get into the root canal system, it's always easier if it's an old root canal, where you have silver amalgam as a core built-up. Today you have core built-ups made resin composites. So once you get the canal there, what we need to understand is to try and locate the canals. It is the first maxillary molar. There is a possibility of having a high incidence of a second canal. So we are using an ultrasonic to try and trough the canal. But once you get the canal spots, the pink spot, what you need to understand is try to use some sort of GP removal system. One of the most practical and the easiest one used by everybody is a solvent. What you could do is drop some solvent into the chamber, use a DG16 probe, and then try and peck that for a couple of minutes. Generally, a lot of us are in a hurry that it should work fast. It still will take about 2 minutes to 5 minutes. So what I would say is you wait with a pecking motion with the DG16 into the solvent for some time. It will soften. Having said this, there are many ways to get into the root canal system. If you ask me, one of my best way to get into the root canal system is heat. You have these down pack devices which can take a temperature up to about 150 degrees till about 220, 230 degrees. They are one of the best. Of course, lasers also have been tried. The second best could be solvent. What happens in solvent is as you go down deeper, if it goes into the periapical area, it may not settle fast. Hence, we would try and delay, postpone, or use less of solvents. Third would be a mechanical way. For the straight part of the canal, either you soften with heat or with a solvent. You can take a probe like a DG16, a micro opener, and start pecking in. Also, you have retreatment drills, you have piezo reamers, you have rotary drills. Anything will be okay provided they are softened. There's also another theory where you can also use without softening, but I would say only in the straight part of the canal, because when the rotary turns, there's going to be heat generation, which is going to be thermomechanical softening of the GP point. At the curve, please use some sort of a solvent. It will really help you. A drop of solvent always helps at the curve. I've written H files and K files, but my favorite would be a K file, a 15 number, not a 10 or lesser, a 15 or a 20, just to again peck, to cross the curvatures, to negotiate the path and maintain the glide path. It's very common for people to deviate at this point. Ultrasonics also would be another use where you can possibly remove the GP or any contents that get stuck on the wall. The best would be combination of the above, because in retreatment there's no single recipe. You need to mix and match techniques. Now, once you've softened it or otherwise, rotaries can play a very important role. All you need to understand is try and use the right side of the rotary file and peck or bite into the GP at the core. It's not at the coronal third, not at the apical third, but somewhere in the middle, you're trying to bite into the GP, and if you're lucky, and if it's like a single cone, the whole cone can come out. Basically, you're trying to convert a retreatment into a chronic looking tooth that is to be treated. Once you remove the GP, you're free of contents. It's like chronic looking tooth. You need to clean and shape it. Of course, you're seeing the video of shaping here, but what I would emphasize more is cleaning. What happens in retreatment files is any companies, any system that you follow, they follow a crown down, larger taper to smaller taper. So when they go to the coronal area to the apical, they are from 8 taper to 6 taper to maybe 4 taper. They're from 30 size to 25 size to 20 size. So when you reach the apex, the idea is when a root canal has failed, it's failed because of not the GP, because of the infected dentine. So 20 size is too less. The theory goes this way: you have to do one size more or at least a taper more. I would prefer 1 or 2 sizes more, which means 20 is too less a diameter. You need to increase the working width to about 30, 35, maybe 40, depends on the case. Most important concept would be an irrigation. Once your master shapes are done, there are plenty ways of irrigation. In this video, you are seeing one form of activation. You have manual dynamic activation, you have ultrasonics, you have sonics, you have rotary. You can use any one of them or a combination of them. But activation plays an important role because it carries the irrigant deep into the dentinal tubules at different parts of the tooth. Especially it has to be done at the apical third. Following irrigation, you do placement of medication. If it's a multiple visit and you have time to wait for at least 7 days to 14 days, one of the commonest or the best medication would always be a calcium hydroxide. A simple water soluble is good enough. You don't have to go for an oil based or any other chemicals. Try and use this medicament, place it in the system, agitate it with manual dynamics, and try and leave it there for it to act. But the concept is this calcium hydroxide should reach the apical third. That's the concept, because zone of infection is in the apical third. A week later, 10 days later, when you call the patient back, open up the dressing, wash off the calcium hydroxide, and here you're drying the root canal. Now, if it's ready for obturation, you can proceed for the next step. When you're drying the root canal, you know you're not just putting the cone directly in, you're putting the paper point cone to go all around to touch into contact with the dentine, because cross sections do not match. And the final one of the steps would be an obturation. Obturation is means to an end. When you're sure, I prefer you use a simple technique of using a master cone, but before which an additional cone to carry the sealer into the system. You don't need to use a lentilo or a bidirectional spirals. Too much of cement will be thrown out. Put a couple of cones in, because single cone glorified obturations don't suit the apical end. But in this obturation, if you see, we've also done a down packing, following which we did a backfilling and completed a case. In retreatments, one thing you need to remember is use of antibiotics will play a role. It's not a must all the time, but sometimes if you think there's going to be a flare up or you have a medically compromised patients, a broad spectrum antibiotics like a cephalexin with clavulanic acid or an amoxicillin with a clavulanic acid is advocated. If you think the root canal obturation is good, you please follow up with a core build up right away. Core build up is actually done on the same day itself. Use etchant, a old technique, a total etch technique, not the semi or the partial etch. Bring in contact with instrumentation, that is to bring in contact. Once it's washed nicely, you put a good bonding agent, following which, if you see the build up that I'm doing here, I'm using a colored core. The colored core is used only because for identification. In the beginning of my lecture, if you heard me, I spoke about going through silver amalgam was easier. Going through resin fillings is that much more difficult now. So what I'd request all of you is please use a colored core on the deepest layer just for identification. It might be your root canal or mine. If it goes for failure, one of us may have to treat it. If you go to the color core like a blue core or to the purple at the deepest area, that will carry you to the pink, which is the GP, and that's how the retreatment becomes easy, and there will be a lot of dentin conservation. This is a step-by-step approach of a retreatment in a concise manner. Thank you.